Good morning, good afternoon, and good evening. My name is Mark Linwood, and today we're going to be going over management of distributive shock and anaphylactic story. In today's discussion, what we're going to be covering is things such as pathophysiology, the clinical features, physical examinations and investigations that we can do, the pharmacology of the medications that we use, and a couple of little random ones. With the management, we're more focusing on the actual distributive shock itself. We're not going to be looking at respiratory or airway or anything like that. Transport considerations, and last but not least, leadership. So the definition. So what is shock? So as we know, shock is defined as a state of acute circulatory failure, characterized by an inadequate tissue perfusion as a result of decrease in our oxygen delivery, resulting in end organ dysfunction and or death. Now, distributive shock is one of the four arms that come under shock. And it is a state of relative hypovolemia due to a physiological redistribution of intravascular fluid, and it is more often than not the result of inflammatory mediators. Now, under distributive shock comes anaphylactic shock. And as we know, it's a quick-acting, multi-system, full-body allergic reaction resulting from the release of inflammatory mediators. So the pathophysiology of distributive shock. So as we can see from the photo, it's got a list of the other arms of distributive shock. So the main ones being sepsis and neurogenic shock, apart from anaphylaxis. So what is it? So it's a relative inadequacy of intravascular volume due to arterial and venous dilation. Now we get that dilation due to inflammatory mediators, and alongside that vasodilation comes an increase in that vascular permeability. All of that combined results in a decrease in our systemic vascular resistance and leads to a decrease in our tissue perfusion. We then result with ischemia, followed by cellular necrosis, and eventually end organ ischemia or dysfunction. Moving on to anaphylaxis. So this should just be a refresher for everybody. Anaphylaxis, we get triggered by an allergen. Body produces our IgE antibodies and they attach to mast cells. When we get reintroduced to that allergen or the antigen, those mast cells degranulate, releasing histamine and leukotrienes, the big ones. But we also get a release of bradykinins, tumor necrosing factor, alpha, and platelet activating factor. All of those mediators in the circulation, they bind to a smooth muscle cells, as well as the blood vessels, resulting in pretty much a systemic vasodilation, as well as a smooth muscle constriction or contraction. And with that vasodilation, as we said before, we get an associated increase in our vascular permeability, decreasing our systemic vascular resistance and subsequently decreasing our overall blood pressure. And we also get constriction of the airways. From there, we get the fluid shift from our intravascular space, moving into the extracellular space, decreasing the amount of oxygen and nutrients that we're being delivered to the tissues. Now, I apologize for the next slide. It didn't really work out as I planned, but here we go. So in the beginning, this is a cellular breakdown of what is happening. So we get introduced to our allergen, whether that's a food, a medication, or environmental things, such as the common one being a bee sting. Allergen is in the system. We then get presented with a macrophage who goes, I might take that to a T helper cell. T helper cell gets it and releases a host of chemical cytokines, main ones being interleukins, and they're being interleukin 2, 4, and 5. And what this happens, this stimulates B cells. Now, along with those chemical cytokines, they evolve the B cell into a plasma cell, and the plasma cell's job is to produce antibodies. But with interleukin 5 on board, it produces a special type of antibodies, being our IgEs. The IgE antibodies then travel to the mast cell where they bind and wait for the second exposure of an allergen. Once that happens, those allergens attach to the antibodies, overcome them, and the mast cell degranulates, releasing those host of inflammatory mediators. So the clinical features. So what we're looking at when we're faced with these patients. So altered mentation is a big one in our severe cases due to a decrease in cerebral perfusion. We're getting a decrease diastolic pressure due to the decrease in our systemic vascular resistance. We get a widened pulse pressure that we see with a lot of our shocked patients. In the early stages of compensation, we'll have that tachycardia, and that'll be pretty much throughout, but we initially get bounding radial pulses. With that, we're going to have following that, we'll have hypotension and the standard symptoms that we see with that. So the patient will become dizzy or lightheaded, be diaphoretic, absent or weak radial pulses or peripheral pulses, and loose radial end up at the brachial, and then finally the carotid. They'll have a low jugular vein pressure, become diaphoretic, and ultimately they'll have a poor mean arterial pressure. With that come hand in hand, we get a decrease in our renal perfusion, resulting in a decrease in our urine output. With that, we're going to get hyperlactatemia due to that metabolic acidosis and the high lactate levels. And with that metabolic acidosis comes obviously a decrease in our pH. The last three are more aimed at the anaphylaxis itself. So we're looking at the respiratory distress, angioedema, abdominal upset, so the MVDs, and the typical skin symptoms being urticaria. Okay, physical examinations and investigations. So the first ones that we're doing is just the visuals. We do that with every patient. So we walk into the room, go either you're well or you're unwell. In this sense, we're going to be looking at their skin color. Are they diaphoretic? Do they have pallor? Do they have urticaria? Is there presence of vomitus? What is the patient behaving like? And more importantly, is that allergen still present? Now, next to our monitoring. So the big one is our non-invasive blood pressure. Ultimately, manual blood pressures are king, but in the critical patient, we're going to fault back to our automatic so that our hands are free to do other things. Cardiac monitoring. So we're going to be seeing if they're just in a sinus tachycardia or they're having actual other arrhythmias, which is going to change our management just a little bit. SpO2 and end titles. Now, with that point below, we'll see that the finger SpO2 may be reliable in the profoundly hypotensive patient. So we're not going to get a good tracing. So if we have them, we can use the earlobe sensors for a more accurate reading. And be palpating for peripheral pulses and obviously auscultating the chest and abdomen. Now, the more advanced measures, if we have eye stats, that'd be amazing. So we can provide a good indicator, the level of tissue ischemia by noting those lactate levels. And by doing repeated readings, we can see if our management is trending in the right way or if we need to step in and do some more further advanced management. Outlines for invasive blood pressures and mean arterial pressures. So we're going to have that constant reading. Is a specialized skill set, is timely, and requires an aseptic technique, which is a very sterile technique and is quite difficult in the pre-hospital setting, as we all know. If we can try and get an indwelling catheter in just to measure that fluid output. So we know that we're getting good perfusion if we are getting output. And lastly, we can use POCUS to see the level of cardiac function that is currently happening. So the pharmacology. So first and foremost, adrenaline. Adrenaline is the key in anaphylaxis. So it's an alpha and beta adrenergic stimulant. So the alpha effect, so obviously is that induces peripheral vasoconstriction. What that does is increase our systemic vascular resistance in the venous return and prevents or even decreases any further edema being on the tissues of the airways. Beta-1 effect, so it increases our heart rate by increasing the SA node firing rate, increases the conduction velocity through the AV node, increases our ventricular irritability, and increases myocardial contractility. Now, the beta-2 effects, as we know, 2 means lungs, so it produces a bronchodilatory effect and assists with that bronchospasm or that bronchoconstriction that is on board. And also it's been known to assist with stabilizing our mast cells by inhibiting mediator release. So it covers all bases. Now, the next one is an adjunct to adrenaline. So glucagon. So glucagon is utilized in patients who are on beta blockers and have been resistant to at least 2 IM adrenalines. And what it does is it bypasses our beta-1 pathways, and it essentially comes through a backdoor to increase our heart rate and our cardiac and our contractility. How it does that is it activates adenyl cyclase. And what adenyl cyclase does is it synthesizes cyclic adenosine monophosphate, or CAMP. I'm just going to call it CAMP for short. So what CAMP is it's a hormone regulator and a neurotransmitter, but it actually works in the heart, and it controls that sort of catecholamine effect by controlling the heart rate and the contractility. So glucagon activates the adenyl cyclase, increases the activity of CAMP, and so bypasses the beta-1 receptors and increases our heart rate and contractility, therefore increasing our stroke volume and cardiac output. Next one is our steroids. Service dependent, main ones being dexamethasone and hydrocortisone. Utilize these to provide an inhibitory effect on those pro-inflammatory mediators. And the main way it does this is it suppresses the release of arachidonic acids. And it's thought to diminish the late phase or even that biphasic reaction that occurs in anaphylaxis. It is currently undergoing reviews because there's been a multitude of studies that have said its efficacy is just not that great, and is it even worthwhile administering? But whilst we have it, it's beneficial to use it. I prefer dexamethasone because when compared to hydrocortisone, the strength is tenfold and it's got a shorter onset of action. Then we're looking at fluids and vasopressors. So obviously, the fluids we use are isotonic, service dependent, whether you use normal saline or Hartmann's, much of a muchness, but they're both utilized for volume expansion due to their similar concentration to plasma, and they can provide that volume without altering the cellular fluid shift at all. Vasopressors, so the main ones we use are noradrenaline and metaraminol. Not routinely used in the shock state due to anaphylaxis because we're going to be utilizing adrenaline. However, there have been studies that have suggested that it can assist with MAP control secondary to adrenaline. Now, it uses this by providing an inotropic and a chromotropic effect, and increases the alpha adrenergic effect. So it increases our overall mean arterial pressure and myocardial contractility without pushing our heart rate to the limit and creating any tachyarrhythmias. So management, first and foremost, we need to remove the allergen. It's pointless to do any management if that allergen is still there. So remove the medication if it's in the mouth, remove the bee sting. Then we're going to go adrenaline, 500 micrograms intramuscular, large muscle mass. So we're going to be lateral thigh, and we're going to be alternating legs with each injection. Simultaneously, we're going to have high flow oxygen therapy on to flood the red blood cells with oxygen so that when we do get an increase in venous return, we can provide the deprived cells with a large amount of oxygen and increase that tissue perfusion. Large IV access, if we can get bilateral, that is going to be gold standard. We're going to give fluid through one, and worst case, then we're going to use the other one for our infusions. The adrenaline infusion, if they're refractory to 2 IM adrenalines, that's when we're going to be looking at the adrenaline infusion. This is going to be very patient dependent. I'll give you an example. I went to a gentleman who was in his late 40s having a reaction to an antibiotic. He was refractory to 2 IM injections, so we started him on an adrenaline infusion, but this patient was heavily medicated for hypertension. So with that in mind, instead of starting at 5 mics a minute, which is the standard, we started him at 1 mic a minute and then gently titrated. As soon as we hit 3 mics per minute, the patient started to become hypertensive, and then proceeded to go into a tachyarrhythmia. He went into a junctional tachycardia. Luckily, he was asymptomatic. We ceased the infusion and he maintained his overall blood pressure and his MAP and didn't require any further management. So that was lucky. Very patient dependent though. Then we're moving on to our second line and third line vasopressor therapies, not routinely used in anaphylaxis, but very handy to have. So metaraminol or noradrenaline infusions. And they're going to be used in the markedly shocked patient. Now, what we're targeting as a MAP of 65 or above, or a systolic blood pressure greater than 100, essentially. Now, transport considerations. So in the metro areas, we are quite fortunate. So all we really have to consider is if I need a higher skill set, how far away are they from me, and versus how far away am I from definitive care? So if it's if they're going to take 10 minutes to come to me and it's only 5 minutes to hospital, I may as well just go to hospital. Or what we really have to think about is what's our closest backup crew to assist with extrication. Because as it says right down on the bottom, they should be transported supine to assist with maintenance of that mean arterial pressure. And that means that they're going to have to extricate them supine as well. We also have the luxury of proximity to hospitals, and we generally have a plethora of hospitals to choose from, most of which can manage these type of patients. The rural areas, that's when it becomes a bit more complicated. So we're looking at longer transport times. A lot of these stations will be single officer, so they don't have any backup. We're looking at the small tertiary centers that are unable to deal with these types of patients. So we're going to have to bypass this and go to the next town, which could be however far away. So we also have to think about, do I have to either stop in at the station to get more medications or stop at that tertiary center to get more medications to actually for me to actually continue to treat this patient without running out of stock. As it says there, if we have to bypass it, it has its own risks associated. Also going to be the logistics of the backup. So we do need backup with these, but we can't do these on our own. So do we have the local fire brigade? Do we have police available? Are there volunteers? Do we have bystanders? Obviously, we can't have a civilian driving the ambulance, so we still need someone of authority to drive the ambulance while we're in the back treating. Most of the time, these patients, if they're unstable, will get aeromedical evacuation. So then we're looking at, is it closer? How far away is the helicopter? Are they going to be able to reach me, or am I going to have to get a fixed wing? How far away is the closest airport, and how am I going to get there? So there's a lot to consider. I take my hat off to the rural guys. They don't know how they do it. Leadership, so the big one. So leadership comes with experience and I guess exposure. So you see the micro guys, the ICPs, as soon as they get on scene, they just take that leadership role. They're Napoleon as soon as they get on scene. They retain composure. As soon as the anxiety kicks in, it's addictive. The scene goes downhill so quickly. Be confident when you speak. Have authority in your voice. Be clear in what you're articulating. And when you are providing a plan, make sure that you're utilizing pauses so that the team can process it, ask questions, and just clarify. Delegate roles to people. When it comes to delegating, so you're going to be focused on the monitor. You're going to be drawing up my medications, and you're going to be sorting out extrication, things like that. It's a typical sort of military resus or field resus sort of setup. When you are a team leader, it's best to have a hands-off approach if you've got the resources. So that way you've got a good situational awareness, you can see everything that's going on, and you can just control better. When it comes to communicating, especially when it comes to medications, make sure that you're utilizing a closed loop communication. So this is where you go, can you draw me up 500 micrograms in a 1 ml syringe? And they'll reply, I'll draw you up 500 micrograms adrenaline in a 1 ml syringe. And more importantly, once you've got the patient in the hospital, or once the job is finished, have a team debrief. That way you can ask, the team can ask questions, you can learn from the experience, what went well, what could we work on, and provide it, if there is feedback, provide it in a way that it's not demeaning. So provide it in an educational manner. And as it says there, effective leadership can initiate great team cohesion and have an optimal result in patient condition and outcome, as well as overall paramedic well-being. Resources or references for your perusal. And thank you all for being a part of today. I hope you enjoyed it.